Hello, dear friends and listeners. It's a great privilege for me to address you once again. This time, we'll discuss a very interesting topic: oral pathology in the daily dental practice. I like to start this podcast by addressing some ideas that have been sold to us that might not be entirely true. What are these ideas? It's basically that the daily work of dentistry revolves around restorative aspects: fillings for cavities, dental cleanings, 3-unit bridges, crowns for fractures, and then all the other variants of slightly more specialized treatments like veneers, teeth whitening treatments, and the famous digital smile design. All of these stem from what would be considered dental work. I want to start by making an analogy about a plane flight. I want to go to Miami, and I hire an airline to take me there from my country of origin. Let's talk about Nicaragua in this case. So the flight would be Managua to Miami, USA. I hire this air transport service at a cost, let's say $600 or $300 depending on the season. No, I know that beforehand I must have all my documents in order, arrive 2 hours early for the flight, bring my properly weighed luggage and hand luggage, wait at customs, and have everything ready: the airplane, boarding pass, seat assignment, and all. I'm waiting at the gate, and probably the plane I'm going to board is already there, parked in the hangar, at the takeoff site, so to speak, where passengers are going to board. But prior to that, there's work behind the scenes. Obviously, all the security and maintenance technicians checking the airplane's fuselage, the engines, making sure everything from the landing gear to the hydraulics, mechanics, and navigation computers is working well, which could take about an hour. If we're not aware, it's something that's happening, but we don't realize it. What we do realize is that we're told to board. We find our seats, buckle up, and wait to enjoy our journey, perhaps sleeping through it or just getting through it in one piece. All this process of evaluation, of review, of achieving the objective is just one: that all passengers can safely reach their destination, and all of this is implicitly included in the cost of my flight. But perhaps if I'm not very thorough, I'll lose sight of this, thinking that what the airline charges me is just for taking me from point A to point B, but there's a whole process behind it. And this airplane example is very much like the work in dentistry in many aspects. There are many things that we access and that perhaps are hidden from areas and disciplines that are fundamental in dental work. But as I say, and I will repeat this several times throughout this podcast, they have tried to sell us some ideas, and sometimes we believe them and take them as an absolute truth. For example, my area of action is oral medicine, obviously closely related to pathology and pharmacology. If you ask me how pharmacology can make you money, I would answer that question with another one. Tell me how your skill to exquisitely and magnificently restore a molar translates into resolving a homogeneous locoplastic lesion, how you handle lichen planus, how you treat a pseudomembranous candidiasis or an atrophic candidiasis associated with a prosthesis, and hold on, because what some might say is that in those cases, I refer them. But let me tell you something. You are a dentist first. You in your blind curriculum. You had the pathology class. You had the pharmacology class. What happened? You not only entered university and learned to place resin restorations and learned to make preparations for bridges. No, you learned a series of aspects that are specific to the area. I say, and obviously, we must respect the territories of action and the areas of work. A malignant myxoma, for example, is probably not something we are accustomed to dealing with, and therefore it will be difficult for us to give it a usual approach in the office because we are talking about the day-to-day of the dental consultation. Now, there are many oral lesions that appear and do not produce symptoms, and they're responsible for making an early diagnosis of those lesions to see what they are about. Obviously, the dentist is responsible. And sometimes it happens that because there is no pain, I don't see anything. And clinical blindness continues to play a preponderant role in everything I do, and I justify it because, well, the patient is not bothered, and unfortunately, there are many colleagues who, for example, use their pharmacological knowledge in a wrong way. Dr. Jesus Flores, one of the greatest representatives of an authority, a gentleman in the medical and obviously dental pharmacological field, this Spanish pharmacologist states that if you learned something about pharmacology and 5 years have passed, it is very important that you haven't had an update on this. You are outdated because the field of pharmacology progresses just as many studies that discuss how likely it is that the filling from the resin composition of the composite or the material that is fashionable at the moment evolves in terms of technology or is modified by some thermal stimulus or some type of photoinitiator that is very similar to K4 or quinone, etc. That seems to be the science behind dentistry, but as I always try to tell you, that's not everything. Imagine a 2-pound birthday cake, a rather large cake, and I come and cut a small piece of it, put it on a plate, and say, here is all of dentistry. This slice of the cake is orthodontics, and this happens often when they sell us these ideas that what you need to know is attention, what you need to know is morphology. What you need to know is that this is what happens, and the market is saturated with it offer. And if not, do this little research, draw up courses in dentistry, and I assure you that in the top 5 of your search, at least 3 advertisements will have to do with the aesthetic part, which obviously is a part of dentistry, a part of our work. But as I have told you, it is not everything. I cannot think that my dental work has to be focused, enclosed, boxed into this. There is a world of oral medicine that we need to exploit and that we need to generate awareness in patients that the dental appointment is not just to prepare me for the molar that broke, the tooth with cavities, the inflamed gum. That post, for example, on many social networks that you go to Instagram and search using keywords like dentistry or put in the famous hashtags with links, and you will find that is teeth, 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 dental restorations gradually, and most of the posts are about that, and here you have to see something in depth. That is, because there is so much emphasis on this point, because clearly what follows is that to restore, I need materials. I need my lamp. I need my spatula. I need my composite. I need my isolation. I need my modified clamp course soon. I need absolute cultural isolation soon. I need to make my materials for digital smile design courses soon. Okay, then it's like, I don't know if you can see this trend, this inclination somehow from dentistry that is migrating to how you have to buy this to be able to do it, but where is the diagnostic ability of the clinician then, where the internist doctor takes my blood pressure, fills out my clinical history, does an electrocardiogram that I don't understand anything about. The producer says, here this means such and such a thing. It's not a device that tells him that. It's just, this is what you have. He simply analyzes those data, processes it, and tells me what you have is such and such a thing, what needs to be done without not achieving with the information gathered so far to resolve with additional tests. And if, with that first appointment and the data supplied, he already has enough elements to establish a diagnosis, here comes doctor and ready sends me a pharmacological treatment. That is, he does not sell. That is the responsibility of the pharmacy. He makes his prescription, gives me my prescription, and goes with the lady to honor the fees. Okay, and this doctor is a conversation that we accidentally had a Dr. Somariba, internist and general practitioner, and myself in a diploma on oral medicine, and we talked a bit about this. Although the topic was not about how it can perform professionally through medicine and oral pathology, but it was about systemic commitments of the patient, and the conversation came up. And it was very enriching to say, the doctor is to say, like, all these years of study allow me to, through my knowledge, say, well, here the approach this, I will send this treatment and honor my consultation. 20, 30, and $40, where the great protagonist of that medical appointment in this case is the clinician's knowledge. Now, the point is that is to say that I should strive to buy more and more materials, instruments to be fashionable and be able to offer treatment in fashion that gives me some type of status in the dental work. But let's not be foolish. The fact of making a greater investment and charging a little more does not translate into that being a net gain. When my restoration costs $40 or $50, are not $40 or $50 that are entirely for me, because there goes implicit the isolation. That is what has to do with the dam. My very expensive spatulas, by the way, my photo or curing lamp, my resin removal, and everything else. That is to say, we start to make a count. Then the truth is that the cost of that restoration versus what I charge, probably from those $40. The first element, the foundation, the cornerstone of this paradigm shift is to educate our patients, to make them see, to transmit information about it, to educate them on this. Make them aware that the statistical data's there. It's enough for you to go to the official page of the International Dental Federation or to the page of the World Health Organization and look up oral cancer. That's all. Do not go to a blog. Go to these official pages. As the famous saying goes, wake up, my friend. Realize, my colleague. Be aware that it's a real problem. It's a growing issue. It's something that happens in everyday life. And if I don't address it in time, it will end up causing lesions that could be fatal to all patients. Do not ask which one and which not. Today, my patients are fine. My patient today is without any alteration, with no risk factors. I cannot answer that question. It means I have to do something about it. So I hope that in this podcast to call for some reflection, if you think that what I've told you contributes a bit to the work in dentistry, if you think it is relevant, and especially if you think other colleagues should hear it, I ask you not only to share it. Remember, this is the channel More Than Teeth, because this is what Generoso and Castillo are about, and I'll see you in another podcast.